colleagues. It's obviously a great pleasure to be here, and I will talk about mistakes in tissue sampling during endoscopy, which is pretty much endoscopic biopsies. I have nothing to declare, and I would start with the first case, which is a case of a screening colonoscopy in which you find the lesion depicted in the three pictures located in the transverse colon. You can take some seconds to look at the pictures. This is obviously not a video, but you can take a good look. And if you find one of these lesions, what should we do? Should we biopsy the center of the lesion and refer accordingly, meaning that if you have carcinoma cells, we would send the lesion for surgery, and if we have just adenoma, we will send it for other type of resection? Should we perform EMR during this screening session? And these are usually busy sessions. Should we do nothing? And nothing means no biopsies and no tattoo, and refer the lesion for endoscopic submucosal dissection? Should we do nothing and refer for piecemeal EMR? Or should we tattoo the lesion and refer for surgery? So please take your time to vote.
So we have a real spread of votes, which most of you won't be able to see. We have lots of D, but a good smattering of B and C as well, and a couple of E's. I think the D's have it, as they say in the Parliament in the UK.
Looks like it. I'm happy that nobody chose, almost nobody chose yay, because we see a lot of this. We see a lot of these lesions biopsied in clinical practice. And so I will take you through these options in the following minutes. And this would be what we think is a mistake. We need to biopsy the center and refer accordingly, because this in fact looks like to be a Paris type 2 granular lesion or granular spreading tumor, and we know that these lesions have a very low risk of invasive cancer, since we don't see them endoscopic signs of it, since we don't see like an absence or irregular mucosal patterns or a nice 3 pattern if we are using NBI. So if we don't see this, these kinds of lesions have a very low risk of invasive cancer, has been demonstrated by the largest series of colonic EMRs published by the Michael Burt group. And we see that in this particular kind of lesions, if located in the proximal colon, the risk of invasive cancer is below 1%. So the likelihood that a biopsy would anyhow change the management of this patient would be very slim. And so there's no point in doing it. The other problem with endoscopic biopsies is that we subjectively think that if we do a biopsy in one of these lesions, or maybe a more not a type 2B lesion, we can hamper subsequent resection. And this in fact is a subjective feeling, but has been demonstrated in the literature. In 100 cases of superficial invasive submucosal cancer, a history of previous biopsy was associated with an increased risk of having a non-lifting sign, and of course of difficulty posterior EMR. You can see by the pictures on the right side, these are both lesions with the same histology. This one was biopsied and this was not, and you can imagine the difficulty we can have in resecting this one. The other question, which of course is perform EMR during the same session, which some of you chose, and I think correctly, and you can do it in the same session if you have the time to do it, if you feel confident, if you have the devices, and perhaps most importantly, if you have talked to your patient that the resection of these lesions can have increased risks. This is very important, and the informed consent, of course, is critical for the removal of these lesions. But the European Society acknowledges the difficulty in removing these kind of lesions and tells that if we don't want to remove them, we can just postpone them to another session or even to another hospital if we don't feel confident enough to remove the lesion. And then the other three options are about how to treat these lesions. And I'm not sure this is settled in the endoscopy field. And of course, people who do endoscopic dissection feel very strongly about it. But the European Society tells us that granular lesions, irrespective of size, can be removed by piecemeal EMR, basically because the risk of invasive carcinoma is very low. And so the first option for these lesions is EMR, and ESD would be reserved for lesions who are not granular or have a depressed phenotype. Surgery has no place, I think, nowadays in the removal of these lesions, except if they are located in difficult locations, such as the appendix or the ileocecal valve. And so the correct answer would be to do nothing and refer to EMR. Of course, you could also remove the lesion during the same session. I will now go to the second case, the second mistake, which is referring to a patient who is referred for upper GI endoscopy due to microcytic anemia. He has atrial fibrillation and is on Pradaxa, and he did not stop the medicine. He took it in the morning of the exam. So endoscopy reveals the following lesion that you can see on the right, which is a gastric ulcer, suspicious for carcinoma. And what should we do in a patient who is on indirect acting anticoagulant? Should you reschedule the patient after cardiology consultation? Should you reschedule the patient after stopping Pradaxa for a week? Should you reschedule the patient after... I see you all that got it right now.
There's some aggressive voting going on this time.
Should we just do one biopsy, or should we just do 4, or should we do 4 to 6?
The poor speaker couldn't even get through the questions. So the predominant answer from the audience is E, with C showing quite strongly as well.
Yeah. Well, and the first 3 items of the question are referring about stopping the anticoagulant drug. And these direct anticoagulants, if we would do a therapeutic maneuver, should be stopped with 48 hours of interval between the last medicine and the day of the procedure. But in fact, we are doing an endoscopic biopsy, which is considered a very low-risk procedure in which the risk of bleeding is below 1%. And we know that for warfarin, for instance, we don't need to stop the anticoagulant. We just need to check INR to make sure it's not on supratherapeutic levels. But for these direct anticoagulants, the European Society tells us that they should be omitted on the day of the procedure. And this, I think, was to be on the safe side of the question, because it's kind of controversial, because we tell us not to take one of the pills, but the Americans tells us that we can continue this kind of drugs, and the Japanese Society tells us that we can also continue the drug, but we should take attention not to make the biopsies or not to make the procedure when there is a peak blood concentration of the drug, which these drugs are very quickly onset of action, occurs in the first 3 hours. So they suggest that instead of omitting the morning dose, we should do the endoscopy before the patient takes the pill, or we should do the endoscopy in the afternoon after the patient has taken the pill. And so this is kind of controversial in this case, but what we know is that several studies have reported that continued antithrombotic therapy, whether it's antiplatelets or anticoagulants, does not increase the risk of bleeding after biopsy. Of course, the number of patients in these studies is not that large, and if the difference is small, we would need a lot of patients. INR should be checked before the procedure in patients taking warfarin, and there are few data on these new drugs. So as I told you, the time of peak blood concentration should be avoided. Some tips about patients on antithrombotics: we should try to minimize the number of biopsies. We should not remove the scope before everything is nice and quiet, before hemostasis is confirmed. We should use endoscopic hemostatic techniques if spontaneous hemostasis is not achieved, maybe more sooner than we would in other cases. And we should remember that antithrombotics have additive properties. Some patients can have triple anticoagulation. They can be on aspirin, on clopidogrel, and they can have also warfarin or one of these new drugs. And these patients, we don't know how to deal with them, so we need a case-by-case evaluation. And the other 2 choices would be about to perform only 1 biopsy or to perform 4 to 6 biopsies of the lesion. And all the literature tells us that we could do 6 to 8 biopsies of these malignant suspicious lesions, even 6 to 12. I have brought you one study, which is a prospective one, with 180 gastric cancers. And the authors found that if they did on a 4th biopsy, all of the tumors were correctly diagnosed if they were ulcerated or polypoid. And only in the case there was an infiltrative phenotype, they would need a 5th biopsy to achieve the correct diagnosis. So the author suggests 4 to 6 biopsies of these lesions, and we should biopsy the center and the margins of the lesion. And so, again, I think most of you got it right. We should perform 4 to 6 biopsies of this lesion, because the risk of not having a diagnosis is superior to the risk of having a bleeding. And I will take you now to the last case, which is in which of the following situations should endoscopic biopsies be made. When we have an 8 millimeter salmon-colored tongue at the G junction, we should do biopsies from the enteral body in a patient that has been previously diagnosed with extensive atrophic or metaplasic gastritis. We should do biopsies of a normal ileal mucosa from a patient with chronic diarrhea. Or should we do a biopsies in a young patient with recurrent dysphagia and with a normal upper GI endoscopy? Or should we do biopsies in all of the above?
Bit of a loaded question, this one. I think already the E's have it. So E is the vote.
Yeah, well, I'm glad I did a question in which I think all of you failed, in my opinion, because everybody was getting it done. Well, I will now try to convince you that the correct answer is actually answer D, but it can also be some controversy around it. We know that if we have a very small tongue of what could be Barrett's esophagus, 8 millimeter salmon-colored tongue, which is below 1 centimeter, we know that this kind of patients, and this is acknowledged by the European Society, the risk of esophageal adenocarcinoma in these patients is low. And so even if there is intestinal metaplasia, the risk is probably not increased, and these patients should not be catalogued as having Barrett's esophagus, and so they should not be surveilled. So these patients probably are better classified as having an irregular Z line, and they should not be classified as Barrett's. And so I would not biopsy just such a small tongue in the esophageal gastric junction. Also, biopsies, and this differs a little bit from the British to the European guidelines, but if we already have a patient that has been diagnosed with extensive gastritis, metaplastic or atrophic, is already on surveillance. And if we surveil these patients, even if we have normal biopsies on the second endoscopy, he should probably not be reallocated from surveillance to non-surveillance. So, except if you see any kind of lesion in these stomachs, patients should be continuously surveilled, except if they have other comorbidities. So we would, again, the biopsies would not change the management of these patients. And if we have chronic diarrhea, we should biopsy the colon and not the ileal mucosa, as you know. And, of course, in a young patient with dysphagia, we have to think about eosinophilic esophagitis, and even if there are no endoscopic signs of the disease, we should do biopsy to exclude the presence of this disease. So, in my opinion, the correct answer would be actually answer D, and the mistake would be, in this case, to ignore the indication, the clinical indication of the case. So, of course, you are invited to visit to see this and other mistakes in the UEG education site, and thank you.
Thank you, Pedro.